Hello and welcome everyone to our afternoon session of an individualized approach to thyroid hormone replacement. My name is Lois Freed and I am a co-moderator for this session along with Matt Faraka. Matt, give a wave out there so they can see you.
Hi, everyone.
And welcome everyone. We have the pleasure of having Dr. Desai with us this afternoon. So without further ado, I'm going to share some words about Dr. Desai with you. Dr. Desai is an endocrinologist and clinical assistant professor of endocrinology at Stanford University in Palo Alto, California. She completed her endocrinology fellowship at the Mayo Clinic in Jacksonville, Florida, with an emphasis on the management of patients with thyroid cancer. Dr. Desai's clinical practice, located in the Endocrinology Clinic Hoover Pavilion in Palo Alto, California, focuses on the management of patients with thyroid diseases, including thyroid nodules and thyroid cancers, and the management of patients with pituitary disorders. She also maintains board certification in neck ultrasonography and internal medicine. And I'm very happy to be here with Dr. Desai as we share Northern California together right near Stanford. So welcome, Dr. Desai.
Thank you, Louis. Good afternoon, everyone. My name is Dr Desai, and as Louis stated, I'm from Stanford University School of Medicine. My clinical practice focuses on thyroid cancer, particularly survivorship care. And I'm excited to be here for a second year in a row to talk with you all. Last year, I did a talk on the ABCs of thyroid cancer. And this year, I picked a particularly small area of that, which is thyroid hormone replacement. And as Louis said, please put your questions in the Q&A, and I'll be happy to answer them at the end of the talk. Okay. So just for a quick outline, I wanted to start the talk off by reviewing the basics of thyroid hormone and the basics of thyroid cancer treatment, which I think are important to understanding the individualized role of thyroid hormone replacement. To determine the thyroid hormone replacement, we also need to know about different risk levels of thyroid cancer, as well as the response to treatment. For the second half of my talk, I will focus on the different TSH goals that patients with thyroid cancer may have, as well as the effects of oversuppression with thyroid hormone replacement. So quickly, what does the thyroid gland do? So a thyroid gland produces thyroid hormone. There are two main types of thyroid hormone, T4 and T3. T4 is the more inactive version and T3 is the active version. The thyroid gland is controlled by the brain, a specific area called the pituitary gland. So the pituitary gland produces thyroid stimulating hormone, also known as TSH, which stimulates the thyroid gland to make thyroid hormone. Your body actually has a very carefully regulated way to make sure that your body has the correct amount of thyroid hormone at any given time. If you have too much circulating thyroid hormone, the body sends a feedback message to the pituitary gland, which shuts down production of the TSH to decrease the thyroid hormone. Opposite, if your body has too little thyroid hormone, it increases the TSH level. This will be important to remember later when we talk about giving back people thyroid hormone after their thyroid surgery. The TSH is used as a marker to determine what the appropriate dose of thyroid hormone replacement is. So quickly, the treatment options for thyroid cancer. Surgery is the primary treatment option, and it's important that this is your best chance for cure. Followed by that, for patients who have intermediate or advanced thyroid cancer, we do give radioactive iodine treatment. Not everybody gets radioactive iodine treatment, but for those of you who have had lymph node involvement or metastatic disease outside the thyroid gland, we do use the radioactive iodine treatment. And lastly is thyroid hormone replacement. This is actually a lifelong process that's done with your endocrinologist, as well as sometimes with your surgeon. And it's important to get you on the correct dose of thyroid hormone replacement. So I just wanted to quickly review what the options for thyroid hormone replacement are. There is going to be a separate talk on Sunday regarding this as well. The first line of treatment is levothyroxine, which is the synthetic version of T4. They are brand names of levothyroxine. You probably know some of them. It's Thyroid, Levoxyl. There's also Tyrosint, which is a gel cap version, as well as a liquid version. There's actually also T3. There's a synthetic form of T3, also known as liathyrine or Cytomel, which can be given up to twice a day to help with symptoms of hypothyroidism. Again, I just wanted to quickly review this, but there will be an entire talk dedicated to this later on in the ThyCa meeting. So one of the questions that I often get for patients with low risk thyroid cancer is they get a lobectomy. That's one of the treatment options where we take out just half your thyroid gland. Traditionally, about a fifth to a quarter of patients require thyroid hormone replacement after surgery to maintain a normal thyroid level. However, the American Thyroid Association guidelines actually recommend that papillary thyroid cancer patients with a lobectomy have a TSH in the bottom half of the normal range, less than 2. So the number actually goes up from 20% to upwards of like 60 to 80% of people may require thyroid hormone replacement. The research has actually shown that there's 2 main determinants that help guide whether you may need thyroid hormone replacement after a lobectomy. First of all, it's what is your TSH prior to surgery. So if your TSH is over 2, then generally you're probably going to require thyroid hormone replacement after surgery to keep the TSH under 2, as removing half will most likely make the TSH rise slightly. Generally, some studies have found that under 1.75 TSH is more likely not to require thyroid hormone replacement. The other thing that also can make a difference is if you have Hashimoto's thyroiditis or TPO antibodies. These antibodies actually increase your chance of requiring thyroid hormone after your surgery. So this kind of can help you determine what type of surgery is most important for you, as if you know ahead of time, are you going to need some sort of thyroid hormone, and how much thyroid hormone are you going to need after your surgery? So that goes to the main part of our talk. So how much thyroid hormone do I need is a question that a lot of patients also ask me. So TSH suppression is also known as giving extra thyroid hormone back to prevent the cancer from coming. As we talked about, TSH stimulates the thyroid gland to make more thyroid hormone. If we remove your thyroid gland, there should be nothing to stimulate. However, if there is a small piece of cancer that's still remaining, extra TSH theoretically may stimulate it to grow. This is actually why traditionally we used to keep everybody's TSH very, very low. So there was a time 15 plus years ago where no matter what type of thyroid cancer you had, low risk, medium risk, high risk, micropapillary thyroid cancer, everybody had the same extra thyroid hormone to prevent the cancer from coming back. So as we got more evidence-based medicine and we researched this further, several studies have shown that the extra TSH actually doesn't improve outcomes in a lot of patients with thyroid cancer, particularly those with low risk. It just gives them extra side effects that I'm going to talk about later. And the other thing that's shown in research is that the TSH suppression makes the most effect in the first 5 years, usually following surgery. And as you get further out from surgery, keeping it suppressed doesn't actually prevent the cancer from recurring. So it's important to know that a normal TSH is on average 0.5 to 4.5, but the lab reference range actually depends on the lab. So it's slightly different for Quest or LabCorp or your home institutions. It's important to know what the reference range is. And the amount of thyroid hormone is actually going to change probably during your lifetime. It depends on your risk of your cancer recurring, which we're going to talk about how that's determined. And it also depends on your response to thyroid cancer treatment. If you have an excellent, a good response, the cancer has been removed, you generally require less thyroid hormone, as well as you get further out from your treatments, you require less thyroid hormone. So risk levels, what is that? Risk levels are usually completed following surgery, and they are independent of staging. So for thyroid cancer, just quickly, there are 4 stages for patients who are over the age of 55. Traditionally, stage 1 is very thyroid cancer that's usually contained to the thyroid gland, versus stage 4 that tends to be advanced thyroid cancer. For those patients who are under the age of 55, the prognosis is actually very excellent for thyroid cancer. So there's only 2 stages, stage 1 and stage 2. Stage 1 generally means that there's thyroid cancer in the neck, in the thyroid gland or in the lymph nodes, and stage 2 is if there's distant metastatic disease. So this risk level was actually determined by the American Thyroid Association, and this determines what's your chances of the cancer recurring in the future. So there's 3 main risk levels. The first risk level is low risk. This is usually thyroid cancer that's only in the thyroid gland, and the chances of the cancer recurring are somewhere around 1 to 5%, depending on how big the cancer was, if it's BRAF positive, if it's a different variant of papillary thyroid cancer. The next status is intermediate risk. This usually is if the thyroid cancer has spread to the lymph nodes, and the risk of the cancer coming in back in patients in this group can be actually slightly higher, which is up to actually 20%. So this involves lymph node involvement, some minor extrathyroidal extension, and the lymph nodes just generally tend to be small, under 3 centimeters. The last group is high risk. So generally high-risk patients have an incomplete removal of their cancer, so they have some margins that can be positive. They can have distant metastatic disease, they can have invasive disease in the neck area. Generally, the risk of cancer coming back in this particular group of patients is actually quite high, up to upwards of 55%, depending on the type of cancer, or follicular or papillary. Those are the kind of 3 risk stratifications that kind of help determine how much thyroid hormone that you need. So in addition to helping determine how much thyroid hormone you need, it actually also helps determine if you need radioactive iodine treatment or not. So patients who are low risk generally don't get radioactive iodine, and patients who are intermediate and high risk do tend to get radioactive iodine. It makes the most benefit in patients who are actually high risk, and the dose of radioactive iodine tends to be slightly higher in high risk versus intermediate risk patients. And lastly, it can also be used to determine the frequency of your monitoring following your treatments. Initially, high-risk patients tend to be followed a little more frequently than those patients who have low risk. The second part, in addition to risk, is what is your response to treatments? So the American Thyroid Association also has 4 different response categories to treatment. And your treatment can include either surgery or surgery plus radioactive iodine. So the first response group is an excellent response. This means that there is no evidence of cancer on your follow-up ultrasound imaging. Your thyroglobulin, which is your tumor marker levels, are low or undetectable if you've had radioactive iodine. So basically, an excellent response means there's no evidence of cancer remaining. So those patients who have had low risk of thyroid cancer, over 85% of them end up having an excellent response to treatment. If you're intermediate risk, there's about a 50 to 60% chance of having an excellent response to treatment. And if you're high risk, unfortunately, there is a much significantly lower chance of having an excellent response to treatment, usually around 10 to 20%. The second category is a biochemical incomplete response. So the thyroglobulin tumor marker, thyroglobulin just quickly is a protein that's produced by thyroid cells. Theoretically, if we remove all of the thyroid cells, the thyroglobulin should be very low. Having a high thyroglobulin generally is associated with your cancer coming back, especially if it's very high, it suggests distant metastatic disease in the chest or the lungs. So a biochemical incomplete response is when you have a high thyroglobulin level, and we do pictures either with neck ultrasound, a chest CT, a PET scan, or a whole body scan, and we're not able to actually find where the thyroglobulin is coming from. Generally, the thyroglobulin levels are ranging from 1 to 10 when we're not able to find where the cancer is actually localized. And the other thing that you could also have is an elevated thyroglobulin antibody or rising thyroglobulin antibody level. So those are also considered a biochemical incomplete response. That's different from a structural incomplete response, where patients actually have biopsy, either biopsy proven neck disease, or they have disease that's located elsewhere in the body, either in the chest, the lungs, the bones, or other areas. And lastly, there's a smaller category of an indeterminate response. This is when your thyroglobulin level is not exactly 0, but it's under 1, or there's very small non-specific findings on your ultrasound imaging that are too small to biopsy, and the radiologist can't characterize them as either normal thyroid tissue, scar tissue, or your cancer recurring. So your endocrinologist or your thyroid cancer doctor will actually, every time you come in for your annual follow-up or a follow-up after your treatment, we'll go through this and determine what kind of response that you're having to treatment. And this can actually change over time. You can have an excellent response, and then in the future, actually your thyroglobulin starts rising, or we find a recurrence, which is the structural incomplete response. And then we do more treatment. And then once we do more treatment, we reassess this. What is your response to the next set of treatments that we did? So that brings me to the beef of our talk here, which is the different TSH goals. So there are 3 main TSH goals, overarching principles. The first TSH goal is 0.5 to 2.0. And then that is no suppression. We are just keeping your TSH in the bottom half of normal. The mild suppression group is 0.1 to 0.5. And the moderate to high suppression is the TSH, which is undetectable, usually less than 0.1. So I'm going to go through each of these and help you determine which goal that you would be in. Of course, this, again, your TSH goals can change as you proceed through your thyroid cancer surgery, especially if you've had some sort of recurrence or if you're doing really well to the treatment as well. So those patients with the TSH goal of 0.5 to 2.0, I generally also want to caveat that it depends on the bottom half or what your normal reference range is. So if the reference range is 0.4, then that 5 changes to 0.4. This is when we're keeping your TSH in the bottom half of the normal range. It's generally used for patients who have had a lobectomy, as well as low-risk patients who have had a thyroidectomy. Intermediate rates, patients who've had an excellent response to treatment, their TSH goal initially is 0.1 to 0.5, but then as they progress and have had a good response to treatment, we back off on the thyroid hormone and make their TSH goal 0.5 to 2.0. The other thing is that, if you have a history of atrial fibrillation, which is an irregular heartbeat, we do also keep your TSH goal usually closer to 0.5. We can actually individualize it even more in these particular broad categories. So your endocrinologist might say that we're keeping it at 0.5 as opposed to the whole group of 0.5 to 2.0. The second mild suppression group is the 0.1 to 0.5. So this, your TSH is just below the normal range, but it isn't completely suppressed. Generally, this is used for intermediate risk patients following their surgery. It's also used for high-risk patients with an excellent response to treatment. And it can also be used in patients who have an indeterminate response, as well as a biochemical incomplete response. So a lot of patients who also have an indeterminate response for one particular visit, it may actually declare itself in the future as either being biochemical incomplete, we find something, it becomes structural incomplete, or what that small little area on ultrasound can actually disappear and it declares itself as an excellent response as well, which is why we keep the TSH goals slightly low, but not fully suppressed. So the TSH goal fully suppression, high suppression, is used in high-risk patients following surgery. If you have a recurrence of cancer, generally after your treatment for your recurrence of cancer, we do keep your TSH goal low for an initial period of time. If you have a structural incomplete response, we keep your TSH goal low, and the area that is shown in studies to be the best is actually advanced metastatic disease or the structural incomplete response. These patients tend to benefit the most from having their TSH lower. So what are some of the effects of having too much thyroid hormone? So thyroid hormone actually acts on all the different organs in the body, which you will learn about in some of the other talks as well. One of the organs that it acts on is the heart, and extra thyroid hormone actually increases your heart rate. This can manifest as having palpitations, which is where you frequently feel like your heart is beating very fast. It can increase your risk of atrial fibrillation. So as I said earlier, atrial fibrillation is an irregular heartbeat. And if your heartbeat is irregular and high, you can actually have a stroke. So that does increase your stroke risk. A lot of patients who have atrial fibrillation are placed on beta blockers to reduce their heart rate, as well as anticoagulations that thin their blood out so they don't have increased risk of stroke. So we don't want to give patients this particular side effect. It's not a great side effect to have. So one of the things that we do is decrease the risk of thyroid, decrease the thyroid hormone if you're at high risk for this, or if you have atrial fibrillation. It also does increase your cardiovascular risk. So we know that in patients who have Graves' disease or too much thyroid hormone for a prolonged period of time, it does thicken their heart muscle. Generally, especially early on, this tends to be reversible. But it also is dependent on how long you've had TSH suppression. So the longer that you have had your TSH suppressed, especially fully suppressed, the more risk of heart damage that you can actually get. And of course, it increases with age, usually the age of being over 65, it does increase significantly. Thyroid hormone actually acts on the bones as well. So we know that extra thyroid hormone can actually decrease your bone density, which can subsequently increase your risk of fractures in the future. Studies have been a little bit controversial about this because the most group that it impacts tends to be postmenopausal women. Younger women as well as men tend to fare a little bit better in their bone health with extra thyroid hormone. So it's important to have good calcium supplementation as well as good vitamin D supplementation to make sure that your bones are healthy when you're on thyroid hormone. And again, as similar with the cardiac risk, the longer that you have your TSH suppressed and the more TSH suppression that you have, the more that it can impact your bones. And having a hip fracture or a spine fracture causes significant issues of morbidity, and it sets you back a lot. So again, we don't want to deplete all the calcium out of your bones and cause you to have very brittle bones with the extra thyroid hormone. Okay. And lastly, I think this topic is actually pretty important as well. So thyroid hormone does affect mental health. We do know that in patients with Graves' disease that they tend to get severely increased anxiety. Extra thyroid hormone actually causes poor sleep and insomnia. This particular study looked at some of those effects, and what they found is that anxiety significantly increases with the amount of TSH suppression that you have compared to a healthy population in patients with thyroid cancer. It can also change your mood. You tend to be a little bit moodier. It can also, when it causes sleep problems, it can cause the insomnia. That's another thing that they found, is that there's the more suppression that you have, the more sleep issues that you can have. You can also have tremors, which is just basically shaking in your hands as well if you're on extra thyroid hormone. So it's important to balance all of these different effects of the extra thyroid hormone with the risk of the cancer recurring. So if your risk of cancer recurring is pretty low, then having these extra side effects is not balanced to keep your TSH very suppressed, because then we're actually iatrogenically creating more problems than the cancer is going to cause itself. So this is just a quick summary of the different TSH goals. So patients who have had an excellent response to treatment that I talked about, but their cancer is gone, they don't see it in the blood work on the thyroglobulin or on imaging of the neck ultrasound. We don't do TSH suppression. We just keep your TSH in the bottom half of normal. The indeterminate response, we tend to do a mild suppression. And as you can see, in patients with atrial fibrillation and osteoporosis, we tend to do a little bit less thyroid hormone, as opposed to patients with no risk, tends to be a little bit more TSH suppression. And this is actually determined as a conversation between you and your endocrinologist, who will obviously go over all of your laboratory data with you, as well as any sort of imaging data with you, and put you into, one of these 4 different categories, as well as your risk status, to determine the dose of the thyroid hormone that you need. So what resources are available? As you all know, ThyCa is an excellent resource for thyroid cancer patients. The American Thyroid Association, the ATA, also has patient information regarding thyroid hormone, thyroid cancer. The ATA actually puts out the guidelines usually every 5 to 10 years regarding, the treatment options for thyroid cancer and how they've changed. There's also the National Comprehensive Cancer Network Foundation, which provides information regarding thyroid cancer as well. So in summary, thyroid hormone replacement is a key element of thyroid cancer treatment. The dose of thyroid hormone is dependent on your initial risk status following your surgery, which is usually low, intermediate, or high risk. And the dose of thyroid hormone is dependent on your response to treatment, either one of the 4 categories: excellent, indeterminate, biochemical incomplete, or structural incomplete. The higher the risk and the more structural incomplete responses, the higher the dose of the thyroid hormone is. Generally, that's associated with more cancer. And side effects of extra thyroid hormone can affect your cardiovascular health, your bone health, and your mental health. So it's very important to balance the risks of these, the impact that thyroid hormone makes versus the risk of your cancer recurring. So I wanted to spend the rest of this talk, I know tons of people might have questions regarding this, so I wanted to give some time to go through the questions as well. Louise, do I just start with the questions?
Yes, thank you so much, Dr. Desai.
Sorry, I know it's a
Wonderful
little bit
presentation.
on the shorter end. Our first question actually is, are there any developments underway to deliver thyroid hormone replacement through a different mechanism other than digesting through the gut? So there is one company that does make a liquid thyroid hormone replacement, Thyroid, which generally tends to be a little bit more absorbent in some patients, but it still goes through the gut. There is an IV hormone replacement if you're unable to take the medicine orally, but generally the IV hormone replacement is reserved only for the hospital because it's not given on an outpatient basis. I'm not sure if there will be plans to change that in the future, but there is an option, which is an intravenous option as well. Okay, so for low-risk papillary thyroid cancer treated with lobectomy, what is the appropriate TSH range in the first few years? So generally for low-risk patients, specifically for patients who have lobectomy, we keep the TSH 0.5 to 2.0 following surgery and generally keep that long-term as well. That is the actual current recommendation standard, is to keep it. Some endocrinologists use the 2.5, which is the middle of the reference range. And then some endocrinologists actually let you be anywhere in the normal reference range. So if you're anywhere in the normal reference range, you won't have any of the symptoms of hypothyroidism. Generally, we don't have data on patients who have a higher TSH in the normal reference range or extremely high TSH in patients with lobectomies, which is why we generally try to keep it at the bottom half of the normal. But again, this is a discussion with you and your endocrinologist, because some patients actually just don't want to go on thyroid hormone replacement. So the next question is, 13 years after thyroidectomy, I have a very difficult time regulating my TSH. It goes from 0.1 to 1.5. It is actually going to change. It's dependent on many different things. So one of the studies has actually shown that TSH changes seasonally throughout the year. So there is going to be some variation on TSH, as well as, if your weight changes, if you're taking brand name versus generic. So I would suggest to help with that, to try a brand name medication If you have Hashimoto's and hypothyroidism, TSH3 post-surgery, would T3 like Cytomel be sufficient medication to suppress? Okay, so generally it is not recommended to take T3 as a therapy by itself. The first line of treatment after surgery is actually T4. And then if you're not regulated with symptoms on T4, you can add T3 in addition to the T4. But it currently is not recommended to take T3 like to be just enough because it's a very short acting medication and it generally has to be taken twice a day. I think I'm confused on the 55 to stage 1 and stage 2. Okay, so the American Thyroid Association and the cancer groups stage the thyroid cancer based on your age as well as the amount of cancer that you have. The cancer staging is done in a 3-part area where the tumor size is measured. The lymph nodes, the N is nodes, and then there's an M, which is metastatic disease. Under the age of 55, there's only stage 1 and stage 2 for thyroid cancer. So anybody who has tall cell variant particularly would not necessarily be a stage 3. It would depend on your age and how much the tall cell variant, how extensive the cancer was from the tall cell variant. But if you're under the age of 55, you should only be a stage 1 if it's located in your neck, or a stage 2 if there's just a metastatic disease. Why would a surgeon prescribe taking thyroid hormone before a lobectomy? So if your TSH is actually higher than the normal reference range, some people might recommend to take thyroid hormone replacement prior to the surgery to help with the surgery, because being hypothyroid, severely hypothyroid may increase your risk of having adverse effects after surgery. But I don't know the specifics of that, but that's generally what most people would recommend doing, is to treat it so that you have a normal TSH level going into surgery. Can you comment on T3 versus T4 to suppress TSH? The first line of treatment is T4, and then if you're still symptomatic on T4 and your TSH is at goal, you can use T3 in addition to that. The contraindications to using T3, generally, there isn't like a specific contraindication to using T3, but if you have heart problems, most people will shy away from using T3 because it does tend to give you a little bit more of a boost and increase your heart rate, especially after you take it. So some people actually can feel their heart racing after they take the medication. How often do you check for high-risk metastatic cancer? You check based on what your risk status is following your surgery. So it depends on the extent of your surgery, how often you would do check for metastatic cancer. How do you recommend addressing endocrinologists or other doctors who do not seem aware of the ATA guidelines? Generally, most endocrinologists should be aware of the ATA guidelines with the TSH goal of less than 2. For hemithyroidectomy or low-risk patients. Of course, these are constantly being updated, so there's a little bit of a lag time between when a guideline is released and when all of the different doctors, get to read about it and change their clinical practice with it. Sometimes people do use higher cutoffs for lower risk patients, but again, it depends on, whether you're having any sort of side effects. If you have bad osteoporosis, some people feel better with their TSH being 3 than they do with their TSH being 1. So it depends on the patient and as well as the endocrinologist or the doctor that's prescribing the thyroid hormone. How do other hormones play in the regulation of thyroid medication? When you go through menopause, your dose of thyroid hormone generally changes as your estrogen level decreases. What we do is we do check your TSH regularly to see what the impact has been of menopause on your thyroid. And short of just checking your blood work to see what the impact is, it would be very difficult to tell what the impact is otherwise. When talking about metastatic lymph nodes in relationship to risk, all lymph nodes, so it depends on the size of the lymph node more than it does on the location. The location does slightly increase the TNM staging, but generally parathyroidal nodes as well as cervical lymph nodes are included. I am on 200 levothyroxine 6 days a week and have recurrent heart palpitations. What would be the appropriate follow-up to make sure the thyroid hormone isn't causing palpitations? If your TSH is actually normal, I would highly recommend to look at other causes of the palpitations other than thyroid. So a lot of people and doctors think that thyroid causes some side effects, but it's always important to verify that the side effects are actually coming from the thyroid hormone replacement, because sometimes they're actually not coming just from the thyroid hormone replacement. So again, if your TSH is normal, especially if it's higher than the 2, then it's probably unlikely to be causing the palpitations. At what point would response to treatment be measured in a teenager? Generally, response to treatment is measured usually about 6 months to a year after surgery, and it depends on whether you get radioactive iodine replacement or not. It is assessed every single visit as after the treatment, but we usually wait like 6 to 12 months after radioactive iodine to see what the full response to treatment is. For high-risk patients, yes, the lower TSH does benefit high-risk patients, whether it's 0.01 or 0.02, probably there's no difference in that. It's important to, have your TSH low, but again, not have significant side effects from the TSH being so low. Yes, so the decrease in bone density with TSH suppression does tend to be a little bit worse for patients who have hypoparathyroidism. Following surgery, it depends on whether it's permanent hypoparathyroidism or if it's transient. Generally, the transient hypoparathyroidism is less of an issue than if it's permanent, and it's important to make sure that the calcium is adequately replaced in patients who have the low calcium levels from the hypoparathyroidism. Wow, there's a lot of questions. The TSH can also impact your muscles as well. I think somebody asked about the picture of muscle spasms and contractions. So TSH does impact all organs, including your muscles. So extra TSH can sometimes make your muscles twitch. Having too little TSH can actually cause your muscles to be strained as well. So it's both ends of the spectrum on how it impacts your muscles. It's how long is the typical wait to determine what type of response you have? Generally, it's usually 6 to 12 months. Again, it determines whether you have radioactive iodine treatment or not. Can depression be treated without antidepressants, but with an adjustment in Synthroid or levothyroxine dose? Yes, it can be if the Synthroid and levothyroxine is causing your depression, but I would say that, once we do some sort of dose adjustment, if there's not really a significant improvement, then I would consider doing antidepressants after that. It's more of an issue with anxiety more than it is with depression. Depression generally tends to occur more with hypothyroidism as opposed to anxiety, and panicking tends to be more with hyperthyroidism and over-replacement of thyroid hormone. What are the considerations of menopause and thyroid hormone replacement? So menopause does affect thyroid hormone replacement. Your dose of thyroid hormone will change as you go through menopause and after you're in menopause. Generally, you require a little bit less thyroid hormone replacement as you get older and go through menopause. But again, everybody is a little bit different because menopause does cause weight gain in a lot of people, and the weight gain can actually cause you to have an increase in your thyroid hormone replacement as well. How long do we need to be suppressed? So the length of suppression actually depends on your response to treatment. So if you were high risk and you had an excellent response to treatment, usually the first 5 years we do the moderate suppression, the mild suppression with your TSH being 0.1 to 0.5. And then after 5 years, if you're still having excellent response to treatment, you can actually start decreasing the dose as well. Quality of life. Yes, quality of life is a significant issue for patients with thyroid cancer, and some of the issues with quality of life are actually the side effects that you may get from the too much thyroid hormone replacement. Armor thyroid. Generally, a lot of endocrinologists may shy away from armor thyroid, which is a combination treatment. There's actually going to be a talk later in the ThyCa meeting about thyroid hormone replacement. Personally, I actually prefer to do it with Cytomel and T4 levothyroxine because the armor thyroid, you have to go up on both at the same time or go down on both at the same time. So I like to do it a little more individualized with the T4 and the T3 separate, but there are endocrinologists that use armor thyroid as well. Generic versus brand name. This is a big topic and a controversy whether brand name is better than generic. Traditionally, brand name tended to be a little more regulated than the generic. The issue with generic also is that if you change your generic brand, the different medications have different fillers and different dyes, which can change the absorption of the medication. So with the brand name, it doesn't matter what pharmacy you're going to, CVS, Walgreens, mail order, you're getting the same medication month to month, as opposed to if you're getting generic, then you're getting whatever the pharmacy has contracted with. You can be regulated on generic. There's some people who do fine on generic, but a lot of times you require sometimes more dose changes with the generic versus the brand name, especially if the pharmacy keeps changing the generic medication. Is there anything that can be done about hair loss besides adjusting the TSH level? After adjusting the TSH level, I would say consider seeing a dermatologist because it's probably not your thyroid, but you have to give it a little while after we adjust your TSH. So generally hair loss patterns of regrowth take 3 to 6 months. So when we adjust your thyroid hormone dose, it takes a little while for the TSH to change, and then it takes a little while for the hair to grow back. So it's a few months before you're going to see a significant change. Get that one. This is actually one of the questions also that I think are important is what are your thoughts on taking antidepressants like Lexapro to treat anxiety from TSH suppression? So different endocrinologists are different camps about this. So some endocrinologists will give you extra TSH suppression and just treat all the side effects. So if you are getting palpitations or heart racing, we put you on a beta blocker. If you're getting anxiety or depression, we put you on a medicine for anxiety or depression. If you are getting really bad osteoporosis, we put you on a medication for osteoporosis. I personally am the camp that, I don't think that giving you extra thyroid hormone to keep your TSH suppressed, if it's giving you a ton of side effects, is worth giving you more medication for. But again, it depends on your endocrinologist or your thyroid cancer doctor, and it depends on how much cancer you have at the time. So it's a discussion about the benefits of the TSH suppression versus, because all the other medicines that we add, they all have side effects, right? So beta blockers have their own side effects. The Lexapro or anti-anxiety medications have side effects. So our first goal is to do no harm. And we want to make sure that, again, that we balance the risk of having all these side effects with TSH suppression versus the risk of the cancer recurring. So if you were a low risk patient, then I would say that we do not need to do extensive TSH suppression so that you don't get these symptoms of anxiety and require other treatments for it. Yes, I'm sorry, the citation fell off for my mental health table. I will get, I didn't realize it fell off, but I will get the reference for you. I will type that in, so I will come back to that. Let's see, the next one is, do patients with partial thyroidectomies have wilder swings in hormones and dose changes? Generally not. If you have a partial thyroidectomy, your thyroid gland is producing some thyroid hormones. So we supplement the extra if you need it. There's some thought that it actually requires less thyroid hormones and less swings in thyroid hormones if you have a partial thyroidectomy versus a total thyroidectomy. Does a higher dose of thyroid hormone replacement cause more cancer? No. So the higher dose of thyroid hormone replacement actually prevents more cancer from growing. It's the opposite of that because we're keeping your TSH low. So that's preventing it from stimulating any cancer from growing. You can, so somebody asked when TSH is suppressed during PTC, you can still have lymph node metastatic disease. And the answer is yes. Sometimes the TSH suppression is not enough. And if the cancer is aggressive enough, it will still grow regardless of what we keep you suppressed. So again, if your cancer is growing with the TSH suppression as well, we do need to balance the risks of, is that actually really working for you? But a lot of times the really aggressive cancers will continue to grow. And the question is, would they have grown faster if your TSH was not suppressed? We don't really have the long-term data on that. What are other options to deal with hypothyroidism, such as weight gain, depression, fatigue, brain fog, anxiety? So hypothyroidism after thyroidectomy is a significant issue. Currently, different endocrinologists do different amounts of thyroid hormone replacement. Some endocrinologists do a weight-based dose to replace your thyroid after thyroidectomy. Some people use it based on your ideal body weight versus other people use it on your actual body weight. And so the doses are a little bit different. There is actually a paper that recently came out that has an automated response to like giving people thyroid hormone and changing it frequently to prevent this, but I think it needs to be used a little bit more to see if this can actually be significantly impacted. What if my thyroglobulin antibody starts showing up repeatedly with no thyroglobulin? So the thyroglobulin assay, the way that it works is that it preferentially actually picks up the antibody levels over the thyroglobulin. So if your antibodies are actually rising, but your thyroglobulin is 0, then that actually might suggest that there's some cancer growing back and you need to do more imaging to see if we can find that. So that the antibody is actually the substitute for the actual thyroglobulin in certain patients. How long after TSH suppression would a patient experience side effects? So it depends on the side effect that you are experiencing. Some people, they feel the heart racing right away. Osteoporosis tends to take a longer time. The cardiovascular issues tend to be a little bit longer as far as atrial fibrillation goes. And these tend to increase with age as well. So being over 65, you're more prone to getting these side effects earlier than if you were younger. How do you manage a rising TSH on Lenvima? So Lenvima is one of the medications that are tyrosine kinase inhibitors. So they're used for patients with metastatic thyroid cancer as a chemotherapy agent. And it actually requires you to change your thyroid hormone replacement. So you have to be on a higher dose of thyroid hormone when you're on Lenvima versus if you're not. So generally, we check the TSH every 6 to 8 weeks and make dose adjustments based on that. If you make it more frequently, like once a month or less than once a month, a lot of times your TSH will actually go down, and then like really down really fast after that, which is why we do it usually every 6 to 8 weeks.
Dr. Desai,
yes,
you're doing a great job of getting through our questions. We are at about 9 minutes before we wrap up the session. So
sure.
Perhaps you can get through another 5 questions or so, and we'll look at wrapping everything up at that point.
Sure. So does the size of the tumor matter with staging of cancer? Yes. So the larger the size of the tumor is, the staging can increase, but that generally tends to increase in patients with the being over the age of 55. So the size of the tumor doesn't really matter with staging if you're under 55. But if you're over 55, then it does, if you are under 1 centimeter versus over 4 centimeters, it does actually change the staging. Do beta blockers and hypertension meds prevent heart and cardiovascular damage? Yes, they do prevent heart and cardiovascular damage from the extra thyroid hormone, but they come with their own set of Side effects with the hypertensive medication, it depends on the type of hypertensive medication, what the side effects will be. And then the beta blockers, they do decrease your heart rate. So sometimes people can feel a little bit fatigued on them, or their blood pressure can actually drop on the medication as well. Every medication has side effects that may cause you to not be able to take the medication. Does thyroid hormone have any sort of side effects that prevent people from taking it? Most of the side effects in thyroid hormone replacement are actually from being, again, on too much thyroid hormone that we talked about, or on too little thyroid hormone. Some people do have side effects from the fillers in the medication, or they do have absorption problems, especially if they have a gluten allergy or celiac disease. There is a specific brand of thyroid hormone, Tyrosine, that is a gel cap with very limited dyes that helps with this. You can also do Synthroid 50 micrograms that has no dye in the medication as well, if you're getting some sort of allergic reaction. But you don't have an allergic reaction to the actual thyroid hormone. It's generally an allergic reaction to something else that's used to make the pill actually round and colorful. What are the considerations of fertility and pregnancy with thyroid hormone replacement if the TSH is not appropriate levels? So this is something to also take into consideration. If your TSH is actually very low prior to pregnancy, sometimes we do change the TSH goals in pregnancy. Of course, we never want it to be very high. The TSH pregnancy goals is actually less than 2.5, so all thyroid cancer patients fall in that goal anyway. But sometimes you can have fertility problems if your TSH is oversuppressed as well. Does consuming sugar affect TSH in cancer treatment? It will not affect your TSH. It does affect some cancers. I haven't seen much data that affects thyroid cancers specifically, but I don't think that anybody should be consuming extra sugar. Because I'm an endocrinologist, so I do have to say that. Diabetes, it prevents diabetes. If a patient is on bipolar medications, would they need more or less suppression? Generally less suppression, but again, it depends on if your bipolar tends to be more with the mania or not. The extra suppression can increase your risk of having manic episodes. How often do you check a bone density in high-risk patients who are suppressed? So you should check a bone density at the time, initial time of the treatment, especially if you're postmenopausal, maybe not necessarily in younger patients right away. And then you can actually check it up to every 2 years, depending on if there's osteopenia or what the rate of decline in the bone density is. But again, that kind of depends on what the bone density results are once you get your first couple of bone densities to kind of mark the trend out.
And Dr. Desai, maybe just a couple more, and we're going to go ahead and wrap up our session.
Sure. My endocrinologist recommends increasing my dose by 2 pills a week should I become pregnant. Is there a better to take a steadily increased dose rather than 2 days of double dose? You can actually do every other day, 4 days a week of half a tablet if you would like. Some endocrinologists actually increase the dose itself by 20 to 30%, and they'll actually change the tablet itself. But generally the recommendations are to do 2 pills and separate them on different days. But again, you just need a higher dose for the baby. So if you are doing 4 half days, you can do that if you didn't want to do 2 extra pills twice a week. Okay. Is tyrosine absorbed faster? I do not know if it's absorbed faster. There's some data that's saying it might be absorbed slightly better, but I'm not sure if it's absorbed actually faster. Okay, I'm being suppressed with the TSH, but I'm intermediate risk, no radioactive iodine. I actually don't know why you're being suppressed so low with no radioactive iodine. Depends on what your response to treatment is. And so you might suppress more if there's an indeterminate response to treatment or biochemical incomplete response to treatment. Okay, how are we doing on time?
We have 3 minutes remaining.
Okay. Have you ever seen hives, rash, or itching with TSH suppression of papillary thyroid cancer and Hashimoto's? Hashimoto's is an autoimmune disease, and sometimes people can actually get an autoimmune reaction which causes hives and itching and rash. Generally, TSH suppression isn't associated with itching per se, but you can actually have an allergic reaction to the fillers and the medications or the dyes of the medication. So you can get hives or rash from the medication if the fillers and the dyes are causing an allergic reaction. What blood tests? Oh, are we done? Sorry, you were going to say something.
Final. You can go for the final question there.
Okay. So what blood test should a patient ask their endocrinologist for? Generally, the TSH goals are based on the TSH level. Free T4 is often checked as well, but it depends on the endocrinologist. The free T4 level is impacted, can be impacted by when you take your thyroid hormone as well. And it can be impacted by the lab's reference range being different for patients on thyroid hormone versus not thyroid hormone. Generally, endocrinologists do not routinely get T3 levels. Okay.
Right. Thank you. Thank you so much, Dr. Desai. And thank you for helping us to understand more clearly the individualized approach that really has to happen when we're working with hormone therapy for thyroid. So thank you so much for diligently going through and answering so many questions for us this afternoon. And again, Dr. Desai, on behalf of the ThyCa organization, Matt and I thank you for being an excellent presenter. Thank you so very much. Take good care, everyone.